Vertigo is either a sensation of motion when there is no motion, or an exaggerated sense of motion. This is the so-called room is spinning feeling and shouldn't be confused with dizziness or lightheadedness. So these are complaints that usually kind of go together, and you have to ask the right questions to figure out, is the patient really having vertigo, is this dizziness, or is this lightheadedness? Now, a key element to that history that you will elicit when a patient presents with vertigo is how long have things been going on. Some causes of vertigo lead to episodes lasting seconds, like benign positional vertigo, while others develop over the course of months or years, like acoustic neuromas, and we'll talk about both of those. You should also elicit whether there is any hearing loss or tinnitus, which means ringing in the ears. Auditory symptoms are more suggestive of a peripheral cause rather than a central cause. Another thing you should figure out is if a patient has started any new drugs recently. And that's because vertigo is a common side effect of certain medications. Now, the class of drugs most commonly associated with vertigo are anticonvulsants, antibiotics, sedatives, analgesics, and tranquilizers. So what are the triggers? They can include anything from a high salt diet to stress, fatigue, head position, and bright lights. In general, vertigo is divided into peripheral causes and central causes. We'll first talk about peripheral. Peripheral vertigo is a problem with the inner ear, which we have pictured here. As stated, it's commonly associated with acoustic problems, which makes sense when you consider the proximity of structures mediating hearing and those mediating balance in the inner ear. Other supporting symptoms of peripheral etiology include sudden onset of the vertigo, as well as horizontal nystagmus. Benign paroxysmal positional vertigo is the most common cause of peripheral vertigo. It is caused when calcium carbonate stones, called otoliths, break free and float within the semicircular canals. The otoliths can break free due to trauma, aging, or infection of the inner ear. Typically, the patient complains of acute vertigo lasting between 10 and 60 seconds. This is following head movement. They might also complain of imbalance, nausea, and vomiting. This can be tested by the Dix-Hallpike maneuver. This is a maneuver in which the patient is sitting on the table and then quickly lowered into a supine position with the head extended about 30 degrees below the body and turned to one side. This should elicit the patient's symptoms as well as nystagmus. Meniere's disease is classically episodic vertigo lasting anywhere from 20 minutes to a few hours. This vertigo is typically associated with fluctuating hearing loss, typically for the low frequency sounds, tinnitus, and a sensation of pressure from the inner ear. This triad of hearing loss, tinnitus, and vertigo should automatically make you think of Meniere's. These symptoms do wax and wane, and it's unknown what actually causes this disease, but it is thought to be due to excess endolymphatic fluid causing distension of the inner ear. Another important cause of vertigo includes infection. So you should always be thinking about inner ear infections. This can happen due to infections within the vestibular nerve as well, and really any other component of the inner ear. Central vertigo is a problem within either the brainstem or the cerebellum. Central vertigo is often of gradual onset, and it's not associated with auditory symptoms usually. Unlike peripheral vertigo, which is episodic, central vertigo is often unremitting. Think broadly about the differential for central vertigo, because it can be caused by anything that causes ischemia to any of these nuclei in the brainstem. Any demyelinating disease like MS could cause the same types of symptoms, and tumors of the brainstem as well as cerebellum. The one that will likely be tested the most is vestibular schwannomas, frequently also referred to as acoustic neuromas. Now, we mentioned this in the beginning. You can see it here on this MRI. Most often they occur unilaterally, and if they occurred bilaterally, what would you be thinking about? You would be thinking of neurofibromatosis 2. One way to differentiate central from peripheral vertigo on exam is to consider nystagmus. Now, In peripheral vertigo, the nystagmus usually occurs after a slight delay and is usually along the horizontal axis. In central vertigo, however, the nystagmus, if present at all, can occur in any direction, including the vertical axis.